The broadcast is now starting. All attendees are in listen-only mode.
Good afternoon, everyone. This is Macy Morin with the National Association of Regional Councils. Thank you all so much for joining us today. Today we'll be discussing regional forecasting. A lot of states, are looking at reopening in the midst of the coronavirus pandemic. And I think this is just going to be one of those really critical tools that we all are going to have to use, using data as our guide to see, if we are stagnant or if we're still going up to the peak in cases. So data and analysis tools like what you're going to hear about today is going to be really critical to that. So before we get started, I will present you with today's presenters. We will have Scott Boggs, the Managing Director of the Department of Homeland Security and Public Safety at the Metropolitan Washington Council of Governments, also known as COG. And then hopefully we will have Chuck Bean, the Executive Director of COG. And then we have Dr. Sid Backham, who's the Manager of Emerging Technology at IEM. Oh, perfect, Chuck, great. And with that, I will throw it over to our first speaker, Scott with COG.
Thanks, Macy. So really, I'm not going to take up a whole lot of time here because we want to give Sid plenty of time to talk about the model is really the most important thing. Want to talk a little bit about how we got here. As the Department of Homeland Security and Public Safety Director, most of the efforts related to the COVID-19 event have been within my department or in coordination with my department. And one of the things that we do is we communicate regularly with our emergency managers and CAOs, chief administrative officers in the region. IEM actually reached out to one of our emergency managers and proposed this. And basically what we got back from our members is it's an extremely valuable tool for on that short range look to manage what's in front of us. The most of the models out there are looking at what's going to happen in 3 months, what's going to happen if we apply this policy, that type of approach, whereas this one's a more straightforward, what do we expect in the next 7 days based on our current information and on what on how things have progressed to date. So with that, we worked with Sid and his team and tweaked a few things here, which I'll let him to speak to. And we distributed this to all of our major decision makers, including public safety heads like fire, police, health officials, I mentioned chief administrative officers. So it's very broadly distributed to our national capital region. And Chuck, if it's okay with you, I'll kick it to you for this next slide, and you can speak a little bit about who COG is.
Great, thank you, Scott. And Sid, look forward to hearing from you again. Looking forward to great questions from around the country. So we're the COG for the Metropolitan DC area. So the map here is about 5.7, 5.8 million people. Of course, it includes 4 major counties in Maryland, and then 5 major jurisdictions in Virginia, the District of Columbia, then a number of municipalities. And in this crisis, we're often finding ourselves at the crossroads of the DC Department of Health, Virginia Department of Health, Maryland Department of Health. Finding that our members, Fairfax County, of course, knows the metrics and numbers for its county, likely has access to the subregion in Northern Virginia. And what Sid has brought is some regional situational awareness, so the District of Columbia can more readily see some of the numbers of the last week or two, and then this Sid's forecast going into the coming week. So I think on the topic of operational situational awareness for operational surge capacity for hospitals, this has been an important tool. And as the country moves towards reopening, that's this data for policy, there's a bit of a difference. So that
Chuck, I believe we lost your audio.
I think we're having some technical difficulties here, Macy. We can just go ahead and move on with Sid.
Sure. Okay. Well, thanks so much, Scott and Chuck, for your introduction there. And just so folks know, if you have any questions throughout Sid's presentation, he definitely recommended that you type in to the Q&A box, and I'll try to ask them actively as he's going through his presentation. But otherwise, we'll definitely have a full-on Q&A at the end of the presentation, so feel free to throw in a question if you see it deemed important enough to answer through Sid's presentation, or just save all your Q&A needs toward the end. So with that, I'm going to throw my screen over to Sid really quickly.
Okay, so let me get this into presentation mode.
Perfect.
Okay,
Looks
and everyone
good.
sees my screen?
Yes, looks great.
All right, thanks so much. So Macy, thanks for inviting me to talk. So today I'll talk real briefly about IEM's history when it comes to modeling medical consequences, give you a little bit of our modeling philosophy, and I'm gonna give you a real short modeling 101. You know, I know when we talk to a broad audience, we can't assume that people have the same level of experience when it comes to modeling. So hopefully I'm not going to scare anybody or talk down to anybody about modeling. And then I do want to talk a little bit about our short-term projections, which we use the analogy of hurricane modeling. And then finally talk a little bit about some of the new capabilities that we've been working on, especially as it pertains to how do we project peak hospital demand. All right. So just a brief history. We've been working with federal agencies and partners for quite some time. I've been modeling for over 20 years. We first started supporting the Department of Health and Human Services in 2003. We were asked to join the anthrax modeling working group. And really that has been the focus of our support for HHS, is how do we look at biothreat agents? What happens if an adversary uses them? And then how do we protect people? So, that's really how we got started. I like to say that we've worked for and supported BARDA before BARDA even existed. And some of our work has been published as well as presented to the Institutes of Medicine panels. And we've also briefed our modeling to the Executive Office of the President. In 2009, we did support HHS with the H1N1 pandemic. So this next slide just shows some of the tools that we've created to support HHS. We started off doing the typical analysis, create reports, create slide decks, and so on. But HHS came to us and said, we love your slide decks, we love your reports, but when we talk to senior decision makers, we can't have something static to show them. We want something that's actually graphical, something visual, something interactive. And so we really have started creating visualization tools. And you can see on the examples on the right there, those are things where anybody can touch, anybody can push buttons, and they can see how those models change and how the outputs change. So what you see on the right are some of our more complex models. I think what we're going to talk about later is that these models that we created for HHS are so different than what we created for COVID-19. And really that's because for, whether we're talking about anthrax or smallpox or other biothreat agents, we have a lot of data about those agents. We have a lot of information about how are people going to react? What is their disease progression going to look like? So we have a lot of information, and we can do those what-if scenarios that HHS is interested in. And so we can do, what happens if we can get mass prophylaxis out there to people and so on? Can we save lives? So that's really in stark contrast to, COVID-19. It's just, we just don't know a lot of information about COVID. And so our modeling philosophy is kind of the analogy, some modelers want to forecast way out there into the future. They want to forecast, how many hurricanes there are going to be in the season. And, this came out a few weeks ago, the number of projected named storms that we're going to have and hurricanes and major hurricanes. But for IEM, our philosophy is always keep it simple and make sure that the data that we present is actionable so that decision makers really can take the information we're giving them and hopefully make informed decisions. And so that's why, as Scott mentioned before, we really wanted to focus in on short-term projections, just 7 days. And again, with our emergency management background, we wanted to make sure that, all disasters are local. And so all decision making and all responses are local. So we wanted to make sure that we could get down our projections all the way down to the county level, because for folks like Scott and Chuck, and probably most of the people on this call, it doesn't help you to know, how many cases there are across the country. And sometimes it's not helpful to know how many cases are there in your state. You really do want to know how many cases are in the county that I live in, that I work in, that, that we make decisions to help protect people. So next is our little modeling 101. So you'll see here kind of the two extremes, if you will, of different ways that people model disease progression. So on the far left, you've got the compartmental model. These are really simple. So when I say a compartment, it's a box. And within that box, there are people, any person that has the same kind of characteristics would fit into that box. So you, for example, wouldn't fit into two boxes at the same time. You would only fit into one box. And in that one box, everybody in that box has the same characteristics as you. So whether, you're susceptible or infected or recovered, those are the compartments or the boxes that people are put into the model. These are obviously less complex, which means they have fewer assumptions, but they run really fast. On the far side, on the right-hand side, we have agent-based models. And so when you hear agent, what that really means is agents equals individual people, right? So each person is modeled. And so sometimes you'll even hear it referred to as individual-based models or agent-based models. And so you could argue that obviously these are more realistic because you can put people into homes and you can put them into communities and you can have people going to work or going to school and so on. But obviously you can imagine every time you have that level of complexity, you've got to have all that knowledge or all those assumptions that say, well, where do they go to school? If you do social distancing, where are they going to go if they don't go to school? If you close the schools down, right? So, and when you run these models, these run slower, right? So you actually have to have a supercomputer. So I use these kind of models when we were at Los Alamos National Labs, when I did my postdoc there. I like to joke and say that, if you had a fly on your head and you're at Los Alamos, they're not going to smack it with a fly swatter. They would probably, hit it with a nuke. So, just because they can run it on a supercomputer, sometimes they do. And so, at IEM, we don't like to be constrained by these extremes. We knew that what we wanted to do was take really the best of both worlds. So we created a hybrid model where we still have the compartments, but what we assume is that those people in the compartments are slightly different. So it's more realistic because inside those compartments, we know that the people, while they share some characteristics, what we've wanted to do, for example, was keep track of their timing. So all these colored dots actually are different because we know when those people came into the compartment, and then because of that, we can determine how long they stay there and when they leave the compartment and go somewhere else. So if you were, looking at the original simple compartmental model, everybody looks the same. You don't know when people entered and people just start leaving. So we wanted to really control that so that it was more realistic, but still has the advantage of running faster. Okay, so the next thing is, as I kind of alluded to earlier, when it comes to coronavirus, there's different ways to do to model that too. So what we chose to do was create a simple SEIR type model. Right on the right hand side, you kind of see the schematic there. On the left hand side, I gave you something to compare it against. What would a complex model look like, right? So if any of you are followers of the website 538, they have a pretty interesting article, and it's actually called "Why Modeling COVID is So Freaking Hard." And so they go through kind of in excruciating detail, the things that we know and the things that we don't know about COVID. So that make it really, really hard to create models for. So, when we created models for HHS, this is kind of how we created it. We would create complex models. So we would know, for example, sometimes we would age stratify it for little children, from 0 to 5 and 6 to 12 or whatever. And sometimes we would do agent-based models where people would go to school and things like that. But with COVID, again, we just don't know enough information, and we didn't feel comfortable doing that. So for example, in our simple model, I would say the S is for susceptible, right? Those are people who can become infected. In the complex model, people are asking, how many actual infections are there? What about, my health comorbidities? How about my age risk factors? Those all impact how susceptible I am potentially. In our model, this is what we call the classic SEIR model. S is susceptible. E traditionally is called exposed, or other people would call it the incubation period. I would be the infectious or contagious, and then R is removed. So to kind of get away from some of that language and some of the ambiguity, we call this E compartment those people that are not contagious. Again, because if you've looked at the news about COVID, there are those questions about, if you become infected and you're asymptomatic, are you contagious? And how contagious are you? And are you contagious before you develop symptoms? And so if you were creating a complex model, and I've seen them out there, they would have these different compartments that say, hey, you're asymptomatic, but you're shedding virus, so we kind of gloss that over and say, hey, you're not contagious, period, right? We don't want to get into semantics about, oh, are you really in the incubation, but you're shedding virus and you're contagious? We just flat out say, this compartment E, you're not contagious. And then the next compartment is you are contagious, right? Again, some of the complex models would say, do we have super spreaders? How long does this virus survive on surfaces and so on? So these are all the complex questions on the left-hand side. And then on the right-hand side, we go from contagious, now you're feeling symptoms, and then people will go to the hospital, and we break out the hospital into people that will use general beds versus people who will use ICU or intensive care unit beds. And then we further break down the ICU into those people who are going to either need mechanical ventilators or the ones that don't need mechanical ventilators, right? And then finally, people move out of the hospital and they're removed. They either recover or they die. But you can kind of see, on the far left-hand side, these are just some of the questions that the complex models have to address. And then on the right-hand side, we went with a simpler model, really because a lot of the questions and assumptions of the complex model really kind of get absorbed into the simple model. And that's great for us because we can still run our models, but obviously that means there's a limitation. If we see a result, so for example, if we see the cases go down we can't say, well, that was specifically because, this jurisdiction, decided to do social distancing strategy A, or, that they chose to do strategy B. We can't go back and say that because our model is not complex enough. But in the same vein, because it's not as complex, we don't have to come up with the literally hundreds of modeling parameters to make that model go. All right. So let's get to the fun stuff. So now we're talking about the short-term modeling that we do, and the analogy that we like to make is that it's like a hurricane model. And so we'll get into that. So the very first thing that we do that I think is important is that we do not, I'm sorry, I'm going to go back one slide. Over here on the right-hand side, what we've got is the R value, right? So people who are contagious, they're going to interact with people who are susceptible, make them infected, and then those people that are susceptible are going to go through the disease process. So this R value is very important. A lot of people will call it by different names. Some will call it the R naught value. Some will call it the basic reproductive number. But in essence, it's really how many people will one contagious person create an infection, right? So when we first started looking at COVID, people were estimating it could be anywhere from 1.5, 2.5, 3.5, 4 people, right? One contagious person might be able to infect those kind of numbers. And so that's something to consider. So as we created our model, the very first thing that we did was we did not assume that the number of secondary infections would stay constant or stay the same over time. And that's really important because those simple SEIR models, they assume that the R value doesn't change. And so really the only reason that you get a peak in number of people infected and it comes back down is because literally you've exhausted almost everybody who's there in the susceptible population. So if you recall, I believe it was Germany, they said at the beginning, we could expect 65% of our population to become infected. And other countries might say, we might expect 75 or 80% of our population to become infected. And really that's a direct consequence of using those simple SEIR models because, like I said earlier, you're not going to have the outbreak start coming down until your susceptible pool is so depleted, 65, 75, 85% of your population's infected, then it will start coming down. So we know in real life that never happens. We never get an outbreak where 65, 85% of the population's infected, not even in 1918 flu, right? There, probably the highest estimates might go up to 25, 35% of the population. All right, we already kind of discussed, we didn't want to create the complex model and we went with a simple SEIR model. And so what we wanted to do, again, was use a hurricane type model. We used artificial intelligence. So instead of telling our model, we're going to assume that the R value is, let's say, 2.5 and see what happens. What we did was we took real data. In this case, real data means the confirmed cases that the jurisdiction has. And we're going to let our AI model work backward and say, I see all these dots that represent our confirmed cases. What parameter values, including the R value, does our simple SEIR model have to have in order for us to fit that data, right? And so we run 11 million simulations to find the best model parameters for each jurisdiction. And you can kind of see, hopefully you can see my mouse. We look at 3 different windows. We look at the very early window. This is what happened in the hurricane. How did it get to where you're at? Same thing with our confirmed case data. And then we get to the more recent window. Let's say the last 24 hours of the hurricane. The way it moves is really going to help you determine where it's going to go in the future. And likewise with our disease confirmed cases, right? The last, let's say 7, 8, 9 days is going to tell you more about what that path of the new cases is going to look like in comparison to the early window. And then finally, the last window is our projection. What everybody's concerned about. Where is this hurricane going to actually move? And where is this outbreak really going to end up. So on this window, we've got the projection of where it's going to go. So once we run those 11 million runs to find the best model parameters, we project out thousands of runs into the future. And it's like a hurricane model, because we will get a spaghetti plot. Some are going to go all over the place, and you're going to have this cone of uncertainty, just like a hurricane. And so you see on the bottom left here, this is what it looks like. The blue dots here and the lines, these are the actual cases of confirmed cases within the jurisdiction. We only show 7, but we actually use all the data that's there. And then as you go to the right in time, we show the projection. This is the best estimate that we have, but we also show, the upper and lower bounds. It could wiggle around there, because we know that the data that we have isn't perfect, right? That's why we have to run 11 million runs. We know that we're going to have underreporting. We know we're going to have delays in reporting. And so that's why we run the runs. That's why we get the spaghetti plot and so on. And we know the distribution of what are all the potential spaghetti plots that we could have. So on a daily basis for over a month now, we send out a PDF that has the short-term projection, 7 days. We do this for all 50 states and territories, and this includes over 350 counties from across the country. And this is all done gratis, no charge to any of the states or territories or counties. What they typically will see is, again, both the graphical representation for the state, in this case Texas, what is their projected growth going to look like? And then they also get a table of all the different counties that we're modeling that show here are the actual cases. And then on the far right-hand side, here are the projected cases that you will see in the next 7 days. So again, this is just a close-up of the Texas projection. We showed Texas because we just spoke to them about a week or two ago. And so, for example, this is our projection for the 18 or 20 counties in Texas. And we stopped on the 17th, so we projected out, and I'm showing you the 18th, 19th, 20th, and you can see the projected numbers compared to the actual numbers. And you can see down here at the bottom, if we look at the entire set of counties that we look at, we did really well in this case, around 101% of the actual projected cases matched up with the actual. Typically what we see is between 10 and 20% accuracy. In this case, we had higher accuracy with Texas. For MWCOG, like Scott and Chuck said, we've been working with them to customize their report. So for example, one of the things that we do is we include a map of their jurisdictions, and we show here are the number of actual cases on the 27th, and then we show them a week into the future. Here are the number of cases that you'll see in each jurisdiction. So as Scott and Chuck said, they're nice enough to share this with folks at the National Capital Region Watch Desk, and those folks also share it with, for example, the Joint Task Force NCR. That's the military community there. And just a few days ago, 5-6 days ago, we started projecting out to 21 days for MWCOG. That was, a combination of talking with folks like Scott and Chuck, as well as the Joint Task Force. They said that while 7 days is great, a little bit farther out will help them plan, especially for their medical needs. And then finally, what I want to show you is the peak hospital demand projections. So instead of just trying to fit the R value, what we've done to improve our algorithm was actually try to fit the change in the R value. So, in some jurisdictions, the R value is growing, and so the new cases are growing, and in some cases they're decreasing, and so we're fitting the change in the R value. And so when we look at this again is an example. We've done the peak hospital projections for the state of Georgia and for the state of Texas. In this case here, you're looking at 2 regions within Texas. They call them trauma service areas, or TSAs. And so, we make very simple assumptions. So, for example, the assumption is that 20% of confirmed cases have to go to the hospital. And then once they're in the hospital, 24% of the hospitalized cases require ICU care. So that 24% comes directly from a CDC study that was published earlier in March, and those were the results that they found. And then finally, for the people in ICU, the assumption is about 50% of cases require mechanical ventilators. So this is a broad set of assumptions, and those are the assumptions that we used, for example, for Texas and the graphs that you see there. But again, those assumptions can be updated. So if we get jurisdiction-specific data, we would use those assumptions. It doesn't make sense to use broad assumptions, but if the jurisdiction has the data that we're looking for in terms of those 3 assumptions there, we can make those changes. So you can see on the left here, in one jurisdiction, TSA A here, we've got the blue dots represent the actual data points in terms of number of new cases per day. And then the dashed blue line represents our projected forecast of what that's going to look like going into the future. The blue lines, again, are the number of cases. And then the red line is the projected number of people that are hospitalized. And so you see that this peak goes up higher, and it's a little bit farther right than the new cases. And that's because, people, as they become sick and go to the hospital, they go to the hospital, but they stay in the hospital. So, based on the most recent data we could find, that suggests that people are staying in the hospital, average length of stay anywhere from 8 to 12 days. And that's why, once they get into the hospital, they stay in the hospital for a while before they can leave. And so that's why, again, the peak of the hospital demand is higher and a little bit further right, or a little bit delayed after the peak of the new cases. So on the top one here, the peak of new cases hasn't happened yet. The bottom one here, the projection is that the new cases have peaked and they're starting to go down. But again, for this projection, we project the date at which these peaks happen and the demand both for hospitalized cases, ICU cases, and then finally ventilators. But that is all that I have, and I want to thank you for listening and open for any questions.
Great. Thanks, Sid. Appreciate it. Just wanting to go back to Scott and Chuck real quick. Is there anything that you all wanted to add on before we go to Q&A?
This is Chuck. Sid, thank you for talking through the model, and I think if you maybe could share just a little bit of interaction that you've had with folks on the ground in the metro area. You mentioned that a little bit, but maybe a little bit more detail, contact with emergency managers, how they're using that information.
Yeah, so the folks at MWCOG are very active. So for example, we've been working with Greg Newsom in Alexandria City, Virginia. He asked if he could see his data a little bit differently, and we were able to comply with his request. We were able to talk, like I said, with the Joint Task Force NCR. They were very happy, like I said, with the 7 days, but they actually said it would be great if we could get out to 10 or 14 days, because that really helps them and their time window, especially when it comes to looking at hospital needs and projected needs, and then being able to, potentially move those assets around in the different regions. So just, some great interaction with the folks at MWCOG. We get questions every once in a while, and we try to address them. But really happy to work with Scott and Chuck and the rest of the folks at MWCOG.
Thanks, and thanks, Chuck, for that question. That was a great point. All right, so we will go ahead and move into Q&A then. For those who do have a question, feel free to type it into the questions box on your GoToWebinar module. But for now, we'll go to the questions that we currently have in queue. First one, how do you choose which counties for a state to report? For example, Pennsylvania has 67 counties, but the report shows only 16. Are they the largest counties, the counties with the most cases, or the counties with the highest infection rates?
Yeah, great question. So we first started doing these projections right around the end of March. And, we looked at all the counties, and we have roughly 3,200 counties across the country. And luckily, most of them had 0 cases, so we didn't have to model all 3,000 counties. But we set up a threshold that said, at that time, any county that had 30 or more cases, we would model. And so that's why for Pennsylvania, there were those 16 counties that at that time had 30 or more cases, and the rest of them had 0. So that's initially how we started doing that. But we have had jurisdictions, come to us and say, we think that this county is growing in terms of number of infections, and so can you add them to your projections? And we will look at the data, and if it warrants, we will add that to our projections. Sometimes we've had people ask, can you add this county? And we'll look at it, for example, and we'll say, well, right now you only have 20 cases, and really that's not enough to project. Or there are some counties where they might have 70 or 80, but literally within the last 2 weeks, they've only averaged about 2 new cases, 3 new cases every day. And so there's not a whole lot of change. So in some of those cases, we don't add new counties, but we have added counties. We have actually added probably over 20 counties since we started.
Great, thank you. Next question. Someone was interested in hearing how the model is being used by individual local governments in a region, and then if there are any region-wide efforts on a joint decision-making using the model as a guide.
So unfortunately, we don't get a whole lot of feedback from the folks in terms of exactly how they use the model results. We get correspondences from people thanking us for them. Sometimes there's questions, and once or twice we were late in sending it out, and they emailed us and say, hey, we're waiting for your reports. We use them every day. Are you going to send it out today? And we let them know, yes, we're sending them out. So unfortunately, we don't get a whole lot of specific feedback in terms of how they use it to inform their decision makers. Like Scott and Chuck said, I think for MWCOG, it was a great way to group them all together because, like they said, there's counties from Maryland, there's counties from Virginia, so they don't have to grab 2 separate reports, but they get one specific report, customized for them, so that again, it allows them to have that common operating picture and that situational awareness of what's going on in their region.
So this is Scott. I'll just tag on to that. There's 2 things I wanted to highlight. The first one is, and I mentioned that the chief administrative officers have been using this. The health officials and emergency managers and CAOs are all working together in most of their local jurisdictions to try to decide, what's their next need, whether that's PPE or standing up additional transport units to deal with COVID patients, or there's a lot of different operational components that have been informed by this. But the other piece, which is the most important, I think, is it's the one place where they can not just see what their projections are, but the projections of their neighbors, which they know will impact them. So it's that regional view with the regional roll-up, sort of treating the national capital region as its own entity as it relates to COVID-19, the spread of COVID-19. So the other piece is that the hospitalization projections. The health officials and hospital folks are looking closely at that to make sure that they understand what surge they may have to deal with in the next 7 days, 14, 21 days. I don't know if that answers the question completely, but that's generally what I'm getting feedback from those groups on how they're leveraging it.
Great, thank you. Next question is, I'd like to hear more from Chuck or Scott on the role COG is playing in responding to COVID-19 and how that fits with public health officials and other public agencies. And how are you working with the municipalities and counties in the region?
Scott, why don't you start talking about a couple of your key committees, huh?
Yeah, sure. Well, obviously the health officials have been in the lead on this, and they're the ones that we've relied on as the subject matter experts. Emergency managers have also played a role in just addressing the needs as it relates to PPE and other things that that our healthcare providers need, including fire and rescue and law enforcement. And what we've done is, for most of those key committees, we've switched to a cadence of a 1-hour coordination meeting weekly, and we discuss what are the current challenges, what are the needs, what's the change in operational posture, and what do we see for the future as it relates to those specific disciplines. That's really helped across the region to not only provide some situational awareness as to the challenges that their partners and neighbors are experiencing, but also sharing ideas about how to deal with those challenges and some of the things that they're doing internally in order to deal with the issues. So with that, there are some very focused priorities that we're trying to address, and those are really driven by the principles that most of you are aware of: hospital capacity, contact tracing, testing capacity, hospitalization data, available PPE, the modeling like we were looking at here today, information sharing, and food security. So with that, I don't want to get too far down into the details, but I'll let Chet take it from there.
Yeah, thank you. I think you get a picture that Scott and his team are convening all of the emergency managers on a weekly basis, and then maybe not as frequently, but convening all the fire chiefs, police chiefs. Another staffer is convening all of the health officers from the jurisdiction. So they're comparing notes, they're learning from each other. Somewhat more challenging step up from that is not just learning from each other, but coordinating or collaborating. So on the collaboration front, it's finding partners, tools like SID and IEM model to give that regional situation awareness that they're not getting from other sources. From those of you who have emergency support function structure, we have an active RESF 8 dealing with health and medical. So that is another instance where the 3 respective departments of health working feverishly for 3-4 weeks on building hospital surge capacity, and there wasn't readily available a tool to support visibility from the district into Maryland, Maryland into Virginia, et cetera, about what that hospital surge capacity is. So in that case, it's a partner from Johns Hopkins University that's providing a dashboard. So these are our technical committees. These are subject matter expert peer committees. Tomorrow we have a call with CAOs, the city county managers of the region. So that's kind of the top of the food tree of the subject matter experts. And we're going to be asking them in the context of Governor of Maryland, Governor of Virginia's orders, what does reopening look like in your county? And then what do you need in terms of coordination across counties? And at the COG board level is the elected officials. And that's where we're yearning to have common statements about what guidelines would be about reopening, cognizant, of course, that a county is within a state. So hopefully that gives a little bit of the flavor and answer to that person's question.
Thank you so much. Just a quick follow-up question to that directed at Scott. Did this committee exist prior to COVID-19? And if so, what issues was it dealing with prior to this?
Yeah, all of these groups existed that we mentioned: emergency management, health officials, health and medical, fire chiefs, police chiefs, and we've really been convening these groups for many years, most of them. They typically are dealing with regular regional coordination activities, whether that be interoperability or operational plans, mutual aid, and just dealing with that. Because we are connected as a region, our capabilities as we look at responding to any emergency is something that requires quite a bit of collaboration on a regular basis. So they're typically meeting on a monthly basis, or in some cases bi-monthly, to talk about those types of issues. And COG supports them in everything from research to best practices and obviously logistical support to make sure that the meetings happen.
Thank you. All right, tossing it back to Sid for another question. Somebody asked about the low model assumptions for mechanical ventilators and wondering whether it matches what happens in reality.
Yeah, so right now, like I said, we assume that 50% of folks in the ICU require ventilators. That has come from both reports from certain states as well as from China. But I would agree that every jurisdiction is different. So for example, one of my friends works at a hospital, and I spoke with him, and he said that for his specific hospital, they're a trauma level 1 hospital. So they get, the most severe cases. And he would estimate that maybe closer to 75% of their folks in ICU require ventilators. So, I definitely acknowledge that every jurisdiction is probably going to see different numbers. Some of them may be higher, some may be lower. Those broad assumptions that we provided were really just for kind of a mark on the wall. I believe they are supported by data, but that's not to say that other jurisdictions are going to have different use levels for ICU as well as ventilators.
Great, thank you. Say if a particular region wants to do something similar to what COG is doing and working with you to look at the specific cases and the projections for their particular region, how would they go about doing that, or who would they connect with at IEM to make that happen?
Yeah, please feel free to email me. My address is right there on the slide. Yeah, we would love to work with other council of governments and create reports they'll help each COG again get better situational awareness and help their decision makers. So please feel free to send me an email, and we'll kind of walk through it and see what kind of report we could produce for them.
Great. While we're waiting for any last questions, I'll just go ahead and thank all the speakers today. Scott, Sid, and Chuck, thank you so much for joining us and talking about this important issue. And for those of you in our membership, we're continuing our COVID-19 webinar series, so be sure to keep a lookout for future webinars. They'll be coming through on your emails soon. Otherwise, I don't see any more questions, so I think we'll just call it a day. Thank you all so much for joining us. We'll be sure to pass along the PowerPoint presentations in an email to you all tomorrow from GoToWebinar, and a recording as well, which will be available in the email, but also on our YouTube page. So with that, I will go ahead and close out the webinar, and thank you all so much for your time. Have a great rest of the day and stay healthy and well.
Thanks, you too.
Thanks.
Thank you, Sid.